brief वाला sine wave हो सकता. Good afternoon, everyone. The topic of my presentation is ECT, electroconvulsive therapy, and my moderator is Dr. Rupali ma'am. ECT is one of the brain stimulating method by electric current which produces iatrogenic seizures to get rid of some serious psychiatric conditions. Biological psychiatrists and mental health advocates have worked to overcome years of stigma and negative public opinion directed towards somatic treatment of mental illness in general and towards ECT in particular. It is estimated that 3 lakh treatment sessions are conducted annually in the United States and 1 million people are treated annually worldwide. Now, the history of ECT. Until the 1930s, options for treatment of psychiatric patients were limited. Psychotherapy, primarily psychoanalysis, was the principal treatment for outpatients, custodial care for the more severe cases, which requires inpatient management. Hydrotherapy with cold packs, water therapy, that is continuous tub baths, prolonged sleep therapy, insulin coma, and Scotch couches were all attempts to use available means to treat the patients. Sedatives, primarily barbiturates, bromides, paraldehyde, and chloral hydrate were the only medications available until the advent of antipsychotics and antidepressants in the 1950s. In 1934, Ladislas Joseph von Meduna, a Hungarian neuropsychiatrist, conducted the first experiments in treating patients with schizophrenia by inducing repeated seizures. Meduna found in his neuropathology studies that the glial cell concentrations in the brain of patients with epilepsy were much higher than normal, whereas the glial cell concentrations in the brains of patients with schizophrenia were much lower. Hypothesized that seizures may be protective against psychosis and that inducing convulsions in patients with schizophrenia could reduce their symptoms. In 1917, Professor Julius Wagner Jurek of Vienna marked a major advance in medicine by inducing malarial fevers as a cure of patients with neurosyphilis, which gave rise to theory of biological antagonism. Biological antagonism, induction of one illness could treat the another. He was awarded the Nobel Prize for Medicine in 1928. Lucio Carletti and Ugo Bini in 1938 first induced seizure in a catatonic patient by electric stimulation and produced a successful response. Before that, camphor-induced seizures were given since 1500 centuries by Paracelsus and others to treat the psychiatric patients. So in 1978, American Psychiatric Association has recommended the use of ECT in treatment of psychiatric illnesses. Basically, the mechanism of action is unknown, though there are some possibilities regarding its effectiveness in psychiatric illness. The first is decrease in the cerebral metabolism. Post-ECT, hypometabolic state like decreased cerebral blood flow and decreased glucose metabolism may be related to its therapeutic response. Cellular mechanism, ECT increases the threshold for future seizure and mood disorder, so future episode may be delayed. Neurochemical changes, all the neurotransmitters and receptors are affected after ECT, mainly adrenergic receptors and dopaminergic receptors. And fourth is the second messenger system, that is change in the calcium entering the neurons, increased activity of the adenyl cyclase, and coupling of the G protein to the receptors. So the indications for the ECT, major depressive disorder and bipolar depression, which have failed medication trial, severe psychotic features are present, active suicidal and homicidal intentions are there, marked agitation and depressive stupor is present, melancholic features are present, and there is poor oral intake. Manic episodes which have failed the response to the mood stabilizers, and there is severe agitation present. The schizophrenia patients who have failed response to antipsychotics, there is more effective in positive symptoms, and catatonic schizophrenia. And other medical conditions in which it is used is catatonia due to other causes, delirium, neuroleptic malignant syndrome, Parkinson's disease, other acute psychosis, and intractable seizure disorder. So now the procedure. Pre-treatment evaluation of the patient and their medication. First of all, the physical examination, laboratory investigation like routine blood investigations, chest X-ray and ECG, the dental examination, X-ray, spine and brain imaging, if any doubt regarding the vertebral column injury, concomitant medications, ongoing medication should be assessed, for example, the mood stabilizers, benzodiazepines, and the antipsychotics. Now the preparation for ECT, NPO for 6 hours, denture and oral cavity examination, bite block and IV line to be established, 100% oxygen at 5 liters per minute, and it is to be stopped at the time of electrical stimulation. Injection atropine 0.3 to 0.6 milligram IM or injection glycopyrrolate 0.2 to 0.4 milligram 30 to 60 minutes before the anesthesia. Anesthesia used general anesthesia with oxygen, thiopentone 2 to 3 milligram per kg IV. Others which can be used are methotrexate, L-fentanyl, ketamine, etc. Low dose should be used to decrease the side effect and anticonvulsant effect. Muscle relaxant is also used to decrease the risk of fracture and post-ictal body pain and injury. Injection succinylcholine 0.5 to 1 milligram per kg IV is used. Atracurium can be given to the patients having pseudocholinesterase deficiency. Effect is marked by presence of fasciculations and its disappearance indicates full relaxation. So now the electrode placement, it can be unilateral or bilateral. Site bitemporally 1 inch above the imaginary line connecting the tragus to the external canthus. For unilateral, it is in the non-dominant hemisphere, either frontotemporal or centroparietal region. Now the electrical stimulation, there are 3 types of pulse wave with seen. First is the sine wave. This is the sine wave. This is the partial sine wave. This is the brief pulse and this is the ultra brief pulse. The brief pulse, it is a series of instantaneously rising and falling rectangular pulses of current with adjacent pulses being separated. In this, the adjacent rectangular, these are separated by brief periods of no electrical stimulation in between. And this is the ultra brief pulse. In brief pulse, this is the pulse width, which is usually 0.5 to 2.0 millisecond. And for ultra brief pulse, it is less than 0.5 millisecond. These are some of the important parameters. This is the sine wave form. This is the zero current baseline. Frequency. Now, what is frequency? It is the pulse pairs that are present per second. So this is the frequency, 1 pulse pair which is present in 1 second. Then brief pulse. For brief pulse, this is the pulse width, which is 0.5 to 2 millisecond. And the frequency for this, it also consists of 2 pulses. So the threshold varies according to the sex and according to the age also. The threshold is more for male than female, and for older age, it is more than the younger age. We should start with dose less than the seizure threshold and increase with 100% for unilateral and for 50% for bilateral until the threshold is reached. To reach the seizure threshold, a dose of more than 3 times the threshold is effective with minimal adverse effects. For unilateral ECT, the dose is 6 times of the threshold. Now, monitoring for ECT. Clinically, the planters are extensive. Seizure can be monitored clinically by inflating a BP cuff machine above the ankle, and pressure kept is more than the systolic blood pressure before infusing the muscle relaxant. EEG and electromyographic recording are the gold standard. Significance of duration of seizure. Seizure for at least 25 seconds is considered to be effective. Seizure more than 180 seconds is called a prolonged seizure. Seizure episode appearing late after ECT session is called tardive seizures. And if up to 4 attempts of stimulation is failed, then the session is postponed. For the post-treatment care, care of the airway and clearing of any secretions if present, 100% oxygen till the beginning of spontaneous respiration and after recovery assessment of the cognitive functions. Now the adverse effects and how to manage them. Headache, confusion, and delirium can be there, which is short lasting. If for more than 30 minutes, it can be treated by giving NSAIDs or benzodiazepines. Body pain, injuries, and fractures, these are also treated by NSAIDs and muscle relaxants. And nausea and vomiting can also be there, which can be treated by giving metoclopramide or ondansetron. Memory impairment is also seen. Both anterograde and retrograde amnesia can occur. 75% of the patients can complain of amnesia and may persist up to 6 months. Factors which determine the impairments are type of the stimulus. In sine wave, more impairment is seen than the brief pulse. Bilateral, it is seen more than the unilateral. More than 3 times per week if the ECT is given. Multiple seizures are there per session. suprathreshold stimulus is there, and concomitant use of lithium and high use of anesthetic agent. It can also play a factor in determining the impairments. Now the treatment schedule, it is 2 to 3 times per week. For moderate major depressive disorder, 8 to 12 sessions, mania 8 to 20 sessions, schizophrenia 10 to 15 sessions, and in catatonia 1 to 4 sessions. Continue the treatment up to maximum therapeutic response, which is determined by static improvement after 2 consecutive ECT sessions. Now for the maintenance ECTs, mainly it is indicated to prevent the relapse or inability to take the medications. See if severe symptoms with depressive features are present, history of high rate of relapse is there, and the maintenance ECT can be given weekly, bi-weekly, or monthly. For documentation, informed consent should be taken from the patient. All procedures should be properly documented, including the seizure events, anesthetics used, and post-ECT recovery. Symptoms response should be documented before and after each session. Now the contraindications. There is no absolute contraindication. However, it is not preferred in patients with any space-occupying lesions and raised intracranial tension, patient with prior history of myocardial infarction, recent attack less than 2 weeks, but can be given after 3 months. Patient with hypertension, cause electroconvulsive therapy causes increase in the cerebral blood flow, increases in the chance of hemorrhage. Blood pressure should be controlled before the ECT. Mortality following ECT rate is less than 0.01% for each patient, less than 0.002% for each of the treatment, mainly due to cardiovascular system or pulmonary complications. Mortality can happen. Now, ECT in special population. In pregnant and lactating mothers, ECT has nil teratogenic and neonatal toxic effects, but more chance of gastric reflux and aspiration is there. Fetal heart sound should be monitored before and after the ECT after 12 to 14 weeks. Near-term pregnancy has a chance of fetal distress, so resources should be available for obstetric and neonatal emergencies. In elderly population, it has a better outcome than younger person in symptom response. Threshold to be given is higher, and there is higher chances of cognitive impairment. Now, ECT in child and adolescents. The indications are general indications. Severe symptoms after an adequate trial of other treatment options have been proven ineffective, or when the condition is considered to be potentially life-threatening. In mood disorders, it can be given for major depression or prolonged or severe manic episode. In schizophrenia, it is not recommended. Catatonia, it is recommended. In intellectual disability, it is not recommended. Then according to AACAP guidelines, the general indication is failure to respond to at least 2 adequate trials of appropriate psychopharmacological agents accompanied by other appropriate treatment modalities. In mood disorders, yes, it is recommended. In severe, persistent major depression or mania with or without psychotic features. In schizophrenia, it is recommended. In schizoaffective disorder also, or less often in schizophrenia. In catatonic patient, it is recommended, but intellectual disability, it is not recommended. And according to APA guidelines, the general indication is other viable treatments have been ineffective, or if other treatments cannot be administered safely. In mood disorders, it is considered. In schizophrenia also, it is considered, and in catatonia. So the adverse effects and special considerations in the children and adolescents are an ECT-related mortality rate was estimated at 2.1 per 1 lakh treatments. The known adverse effects of ECT in adolescents are similar to those reported in adult population: headaches, nausea, muscular pains, confusion, and transient memory impairment. The available literature does not suggest a greater level of cognitive dysfunction in children and adolescents after ECT as compared. Patients given ECT did not differ significantly from controls in school or social functioning. The 2 main complications merit caution when performing ECT in the adolescents, the first being prolonged seizures and the second is the tardive seizures. Prolonged seizures are defined as seizure lasting more than 180 seconds and may occur in up to 10% of the children and adolescents treated with ECT compared with 1.1% reported in the adults. Tardive seizures are a rare but potentially serious adverse effect. Propofol as an anesthetic may be useful alternative when prolonged seizures are feared because of its known propensity to shorten the seizure duration. some of the do's which are to be done when giving ECT, cognitive assessments before, after, and at 3 to 6 months after ECT should be always be carried out. Bilateral electrode placement may be more effective than unilateral placement for the manic patients, especially in patients who are catatonic, unable to take nourishment, floridly psychotic, or severely suicidal. Bilateral treatment is recommended. Use of brief pulse and an adequate dose of electricity are recommended. ECT in youth should start at the lowest possible electrical dose that is sufficient to induce a seizure, because younger patients have lower seizure threshold and therefore may have a higher risk of protracted seizures. So the status of ECT in India after Mental Health Care Act 2017. Is the ECT banned? No. As per Section 95 1A of Mental Health Care Act, use of electroconvulsive therapy without the use of muscle relaxants and anesthesia is a prohibited procedure. According to Mental Health Care Act, unmodified ECT cannot be administered in a patients of any age group. Section 95 1B of Mental Health Care Act states that electroconvulsive therapy for minors is a prohibited procedure except in situations when the treating psychiatrist feels the need to use the ECT. Section 95(2) states that, notwithstanding anything contained in Section 1, if, in the opinion of psychiatrist in charge of a minor's treatment, electroconvulsive therapy is required, then such treatment shall be done with the informed consent of the guardian and prior permission of the concerned board. It is also important to remember that, as per Section 94 of Mental Health Care Act, ECT cannot be given as a part of the emergency treatment. These are my references. Yeah, it cannot be given like emergency procedure. It cannot be given. Like we need a proper, first of all, informed consent should be there, and all the investigation and pre-anesthetic checkup after that only could be given, not as an emergency procedure. But ma'am, now it can. So, brief pulse. Sine wave is the previously it was used, but now brief pulse is used, and now it's ultra brief pulse is also there now. This is the sine wave. This is a normal sinusoidal wave, which was used previously. Now we use the brief pulse. In brief pulse, there are series of instantaneously rising and falling rectangular pulses of current. And between these two adjacent pulses, there is an area of no electrical activity present in the brief pulse. And nowadays we use brief pulse only. And there has been studies also in which there has been shown that for brief pulse, the ECT which we give through brief pulse, they have a chance of lesser cognitive impairment as compared to the sine wave. And it has a pulse width of 0.5 to 2 milliseconds. And ultra brief pulse, it has a pulse width of less than 0.5 milliseconds. Ma'am, the time duration. Then we use the frequency, which is seen in hertz. Then the charge which we are giving, it is in millicoulomb. And then the seizure duration and the type of seizure that we see, which we are. सर जो ऑटोमेटिक से जो मोड है उसमें जैसे हम टाइम एडजस्ट करते हैं 60 hertz.
अगर नेक्स्ट टाइम अगर मान लो नहीं हो तो अपना भी
सर
नया इंक्रीज को ले लेते हैं, right?
सर हम खुद से ही सर नेक्स्ट टाइम विद इन अगर सर 20 सेकंड से कम का सीजर आता है तो सर खुद ही वो नेक्स्ट हायर उसमें जंप कर लेता है। आंसर इसमें 9 तक है। 540 मिली कूलम इज द मैक्सिमम चार्ज इन ऑटोमेटिक। So,
2.5
सर 62.5 है। फ्रीक्वेंसी सर इतनी ही रहती है सब में। सर स्टार्टिंग हम 120 मिली कूलम से करते हैं। 60 से स्टार्टिंग होती है बट वी स्टार्ट फ्रॉम 120 मिली कूलम।
अगर उसका सेकंड सेशन होता है तो किस स्टेज पे आता
इंक्रीज करके
है? हर बार
सर बट नाउ वी आर
अगर मान लो कि तुम अगर 12 सेशन दे रहे हो तो कैसे बढ़ाओगे ऐसा? यूजली जिसमें लास्ट सीजन है होता है उसमें अब कैसे बढ़ाओगे ऐसा? वो प्रेस करके रखो ना तब तक
तो हम रिलीज कर देते हैं सर। एक इंक्रीज करके देते हैं। 30 35 40 सेकंड्स का आता है तो सर सेम उसमें सो ऑलमोस्ट कोई कोई तो सर 100 ही देते हैं। प्रोपोफॉल 100 मिलीग्राम।
1 मिलीग्राम
सर वो मोस्टली कोई कोई तो 100 ही देते हैं सर डिस्पाइट ऑफ द बॉडी वेट दे गिव 100। हाँ सर काफी देर लग सर इंड्यूस नहीं होता सर। इवन किसी किसी एक्टोमॉर्फ पे जैसे 50 60 केजीज में भी कई बार सर 120 130 भी देना पड़ता है इंड्यूस। And ketamine, we have also given here also in case of depression. Depression के patient में मैम ketamine induce, they use ketamine to induce as an inducing agent. Yes. Yes, sir. Please, sir. Two. Two drugs respond to the
How I did. What will be
Yes. Ma'am, benzodiazepine. Ma'am, anti-epileptic medication.